acknowledge that.
So I'm honored to be able to speak with you all today. So far, I think that this has been a great event. Just listen to the panelists and listen to Miss Sarah talk. It's just been fantastic. And so what I'm here to do today is to talk about how can we further support our clients through gender affirmation and just give you a better guide on, how we can really be a support. Um, and then, oh, you have to advance it. Sorry, Letitia. I can also do that if you would like. Share my screen. Yeah, I can do that. Oh,
You're muted, Dr. Flores.
let's see. That might be easier.
Yep. Why don't you try that now?
All right. Does it appear to be working? There we go. Right. So like Dr. Flores said, I'm Samuel. I'm a licensed clinical social worker. I graduated from the University of Tennessee College of Social Work, so special place in my heart for UT. You already talked about psychotherapy and forensic services, where I'm proud to work. We really specialize in mental health care for the LGBTQ plus population in the region. And we are located in Maryville. And one of the things that I like to disclose is that I am a transgender person. And so I get the special honor of being a transgender clinician. And on that note, you can see the title of this slide is Ask Me Anything. One of my transgender heroes, it was one of the first transgender men I'd ever actually met after coming out, had this big button that just said, Ask Me Anything. And I really appreciated that because it gave people permission to ask the hard questions. And it's kind of the odd, creepy questions that sometimes we would get asked as transgender people about, bottom surgeries and things like that. But this is a time to ask me anything, and I open that up to you all. Ask me the odd, creepy questions and learn from me so that we don't have to do that to our clients. And then today's learning objectives are going to be to describe the personalized process of gender affirmation, including common social, legal, and medical elements. I'm using the term gender affirmation versus the word transition. It tends to be more of the more accepted term these days. As Miss Sarah was talking about, our language changes all the time, and this seems to be the most appropriate, and I think my preferred word for transition is gender affirmation. The second objective is to describe the clinician's role in supporting clients through social, legal, and medical gender affirmation. And the third objective is to learn to write a letter of support for clients, for them to access gender affirming medical care and also document for purposes of legal and social gender affirmation for documents and things. I like to establish some just safe space rules. I learned this, picked this up from Dr. Garwood during a presentation that I attended that she put on regarding transgender people. And sort of, I think these are good rules for here and everywhere, even in our own practices, is that we respect and honor everyone's unique experiences. We listen intentionally to understand. We acknowledge that we all make mistakes and will continue to. And then we're open to changing our own perspectives based on what we learn, not just from what we have already known. And so I hope that you all will bring that here and also take that home with you wherever you're practicing. Just a short list of key terms. Ms. Sarah did such a great job of defining all of these things already. I'm not going to read these word for word, but I wanted you to have them just so that we're all on the same page when we're talking about these specific terms. As I described earlier, I'm going to call like transition gender affirmation, and that's the process of making all of these, social, legal, and medical changes that help us to, recognize, accept, and express one's gender identity. Gender affirming surgery or any kind of like surgical procedures that modify a person's body to help kind of establish that congruence between what's going on the outside and what's going on the inside. Gender affirming hormone therapy, that's the feminizing and masculinizing hormone therapies to help our bodies match our brains. And there's also gender affirming, like, like the hormone blockers. They're not necessarily gender affirming, but they are an important component, especially when you're working with adolescents that are post puberty. Gender dysphoria is the distress experienced by some people whose gender identity does not correspond with the sex they were assigned at birth. And I do think it's important to note that not every transgender person is going to experience gender dysphoria, and that gender dysphoria can wax and wane depending on where a person is in their, in their gender journey. That sometimes, someone may have a really difficult day. They may be having a difficult week or a difficult year, and that, even post gender affirming treatment, sometimes gender dysphoria can pop up. And I think it's important for us to recognize that. And then just the word transgender, which describes a person whose gender identity and sex assigned at birth aren't congruent based on traditional expectations of gender. I put this hyperlink in here. It's for the LGBTQIA healtheducation.org. They have a fantastic glossary of terms that is updated. I love it, and I will frequently share that resource with my own clients and their parents, and their partners and families, so that people can learn to speak the language, using the correct language. One of the reasons that I was so excited about this particular conference is to share, how can we make these experiences for our trans clients better? And I wanted to put a few slides in here that just talks about why this is important. I think it's been mentioned previously that, historically the 0.6%, of adults in America, that's 1.4 million people, have identified as transgender. The most recent statistics that I've been able to find actually bumped that up to like 2.7 adults. I think that was worldwide. And then 1.8% of adolescents. And, that's a significant slice of the population. Just for some comparison, for prevalence rates, 1 to 2% of people have red hair in the general population. And so we're talking about, roughly equal to the number of redheads that you might see in your practices, right? And we want to honor their experience and be able to meet them where they are and provide that competent care. Another study that I was reading recently talked about a 20-fold increase in the percent of people that are presenting for trans-related care, for gender-affirming care, from the mid-70s to 2015, and this is worldwide. This was, there was a study that was done in the Netherlands, and then another study that was done on several other countries, and those statistics matched. And it's our population is growing, and it's becoming more and more prevalent, which, again, is the reason why we need to learn how to best meet the population's needs. More statistics and reasons why it's important to develop competence in treating transgender patients is the significant risk of harm by not providing competent care. The stories that that I've heard from other trans folk of being told they were too pretty to transition, or too handsome to transition, or that they're going through a phase, or that they'll never find a job, or this is, you're probably just depressed. When we're undermining the very core of who these people are, and that is hurtful. And the significant lack of LGBTQ plus education that is provided in medical education. The research that I could find, suggested that there was an average of about 5 hours of medical education that was dedicated to the LGBTQ plus population. And that might vary depending on the school, but that was the average that I could find. And that's not very much. And certainly not for the complicated and integrated issues that can present in the population. Suicide attempts, as Ms. Sarah was talking about, in the trans population, 18 to 45% have attempted suicide, somewhere in there, versus 4.6% of the suicide attempts in the cis population. So it's roughly a third or higher, 3 times or more higher. So it's a very serious issue that has potentially lethal consequences if we're not providing the competent care. as we talked about, healthcare providers do not receive adequate training to care for their transgender clients, even by their own admission. Um, this particular study talked about, that providers, specifically, medical providers, talking about, their perceived need for more education and recognizing that they need to be educated to best serve their transgender clients. WPATH, which is our recommended guidelines that we're following, in the standard of care version 7, does say we need to have ongoing continuing education for any practitioner that's going to work with a transgender client, which is why we're all here today. So well done to you all. Two other statistics that I think are very important is that 20% of transgender or gender nonconforming folk have reported being denied care just on the basis of their gender identity. And 30% of transgender people have actually postponed seeking care due to fear of harassment and violence in the healthcare setting. If it's okay with the group, I'm gonna share a couple of stories about, my own experiences coming out, going to pursue top surgery and being misgendered by the surgeon staff. And, it was humiliating, being there, for this really sensitive, sort of care about a part of my body that caused me a lot of shame and discomfort. And, to be called by the wrong name, it was very humiliating. Luckily, the surgeon was not transphobic and was very competent and corrected that issue, which I really appreciated. More recently, I participated, like Corey, in a clinical trial for a different medication for COVID, and that was a fiasco. These people had zero competence about how to treat a transgender person in this medical setting. I'm marked male because I'm a male, right? And there was no other option to indicate that I was trans. And then we get to, medical history to make sure that I qualify for this trial. And I've had to report that I've also had a C-section, and they were very confused. And I actually overheard them talking about, well, this person, they got to mark female because they're really a girl. And it was humiliating, again. And I had to spend a great deal of my own time educating when really I just wanted to be part of the solution to this pandemic. I felt it heavy on my heart to do this and engage in that work, only to be humiliated. And after I spoke up for myself, glad, happily to report that, they did come back and make that okay, and apologize. And hopefully the next person won't have that problem. We're gonna move on to just sort of overall definition of gender affirmation, also known as transition, right? So we've got different dimensions. We've got this social gender affirmation that includes changing our gender expression, going by our chosen name, introducing our pronouns, beginning to live life, in an authentic manner that more reflects who we are. Legal gender affirmation includes legally changing our name, our gender markers, getting our documents all in line, our driver's license, birth certificates, if we are able to, our passports, all of these, social security cards, all of these different documents that we need to get jobs and to be able to travel and all of these things. And then, of course, there's the medical aspect of gender affirmation, and that includes blockers for adolescents, and then also some trans feminine adults. Hormone replacement therapy, that's typically what it's called, or gender affirmation hormone therapy. Chest affirming surgery, also known as top surgery. Genital affirming surgery, like bottom surgery. Hair removal, vocal therapy, facial surgeries, other body surgeries that enhance the congruence between one's body and the gender that they identify. It's important to recognize that gender affirmation, it's a highly individualized process. There is no prescribed way to transition. What helps one person may not help the next person. What one person wants as far as what gender affirmation means to them may be completely different from another person that has a similar gender identity. Examples, I meet lots of people that, they want to take masculinizing hormones that may or may not identify as male, but that prefer a deeper voice or would prefer to grow some facial hair. I know lots of transgender people, even that exist within a binary idea of gender, um, which means identifying either as male or female, that do not want to do genital surgeries or do not want to do chest affirming surgeries, or that cannot or don't want to use hormones. And that doesn't mean that they're not trans. It just means that whatever their gender affirmation process is their own definition. And I think it's really important for us to meet the clients where they are and support what their transition, what their gender affirmation looks like for them, instead of forcing or pigeonholing them into a certain way to do this process. Guidelines, you can see I've put flexible guidelines even in WPATH. It talks about these are not fixed rules. These are these are starting points. These are guidelines, recommendations, and that we need to meet the people where they are. We need to make individual treatment plans for individual people. There is no rule book for how to do this. And so on this slide, I've listed the WPATH standards of care. This is the seventh edition. They are working on the standards of care 8th edition. I believe it's due to be released in December. The clinical guidelines from the endocrine treatment of transsexual persons. They have some clinical practice guidelines. The APA has a code of ethics, or guidelines rather, for professional practice with transgender and gender nonconforming folk. And then, of course, the NASW actually has a code of ethics, which is very important for those of us practicing social work to follow. And these are great guidelines, especially if we take them all together and make the most sense for each individual person as we're encountering them. Diagnosing gender dysphoria is probably one of the most important parts outside of just meeting the person where they are. Not every transgender person is going to present with gender dysphoria or even present for treatment around their gender identity. But when we're talking about medical affirming care, and doing things like gender affirmation / transition, the diagnosing part then becomes very important, because this here becomes how they are able to access the care that they need. And so these are the criteria for adults. And so they need 2 out of the 6 of these things for at least 6 months that are causing them, some sort of distress or impairment in social, occupational, or educational functioning. And so we're seeing like an incongruence between one's experienced and expressed gender and primary or secondary sex characteristics, or anticipated secondary sex characteristics, a desire to be rid of somebody's primary or secondary sex characteristics that is, so that can be more in line with how they feel on the inside, a strong desire to have the characteristics of another gender. I love that this says another and not the other, because it reflects the spectrum that exists of gender, that we're not talking either male or female, we're talking whatever somebody is and how they identify, which can be somewhere on the spectrum. Number 4 is a strong desire to be of another gender, a strong desire to be treated as another gender, a strong conviction that they have the typical feelings and reactions of another gender than their assigned sex at birth. Diagnosing gender dysphoria in children is a little bit different. Again, we've got this incongruence between one's experienced and expressed gender and assigned sex at birth. And they need 6 of the following, one of which must be the very first criterion, which is indicated by the double star. And they also have to have significant distress in social, occupational, educational functioning for at least 6 months. So the first criteria is they have a strong desire to be of another gender, or insisting that they are, right? A strong preference for toys and games, activities that are stereotypically used, or used that they want to play with boy toys, but they're assigned to be a female, or they want to play with dolls and they're supposed to be a boy. Number 3 is a strong desire for the physical sex characteristics that match one's experienced gender, a strong dislike of one's sexual anatomy, a strong preference for cross-gender roles in make-believe play or fantasy play. In boys, a strong rejection of typically masculine toys and games, and avoidance of like typical boy activities, rough and tumble play. And then for girls, for people assigned female at birth, it's a strong rejection of typically feminine toys, activities, and games. The next criteria is cross-dressing or simulating attire of another gender, and then a strong preference for playmates of another gender. And so these are sort of what we're looking for, not sort of, this is what we need to diagnose gender dysphoria in children. This is people who have not yet reached puberty. So how do we support social gender affirmation? The best way is, we're going to meet them where they are. We are going to believe them. We are going to support them. We are going to let them tell us what they need, and we're going to provide education for them, and talk about, how can we feel better. And sort of the way that I would, and the research indicates, is the very first step is creating a safe, non-judgmental space. I don't know if y'all can see my space. I'm not going to show you the whole thing. It's a little bit messy, but I've got my rainbow Mickey ears and flags and stickers, and people know when they walk into this office, it's a safe, non-judgmental space. Other ways that we can do this at our different practices is with our paperwork. Instead of it being, check male or female, let it be a blank and let people self-identify. Write in how they identify. Train your staff, train all the people that are encountering your patients so that they are having an affirmative, an affirming experience at your clinics. And that goes back to, when I had top surgery, fantastic surgeon, the staff made that a horrible experience at the beginning. They redeemed themselves, but creating this space where someone can go and feel safe. The next thing is really doing a thorough biopsychosocial spiritual assessment, not only for things gender related, but also for other comorbid mental health diagnoses that may need to be supported. Other aspects of like social support, spiritual health, and a lot of the clients that I've encountered, they report actual like religious trauma, and that's that rejection from those spiritual families or religious families or church homes, that are no longer affirming for them and no longer are safe places. And then being able to provide a good, solid psychoeducation regarding gender dysphoria, and different treatment options, different ways to alleviate gender dysphoria, including all the risks, all the benefits, educate about gender identities, using their language, and asking when you don't know, learning what you don't know. One of the things I wanted to include, and I should have included it on this slide, is when we're talking about treatment options for gender dysphoria, including the risks and the benefits, is really fertility. That is something that's frequently overlooked, especially as we start to treat adolescents with hormone therapy, because they might not have thought about that yet. And so really talking to them about what it would mean for them if they weren't able to reproduce later, with their own, biological material, and what it would, is it accessible for them to engage in sort of sex cell preservation, and using gender neutral language, using language that's not humiliating to them. That's another anecdotal piece, is that one of the reasons that fertility discussions are hard is, we're talking about genitals, we're talking about pieces and organs of these individuals that make them incredibly uncomfortable. And so if you're talking to a transgender woman about sperm, it can with an adolescent, it can feel uncomfortable for them and make them feel extremely dysphoric. So guarding our language about how we're talking about bodies, but they do need to be aware of things like the risks. What's the good part of hormone therapy and surgeries? What are the scary parts? What are the non-good parts, like going bald or not being able to to reproduce later on? And so we need to really seek to know those answers and provide those for our clients. Other ways that are really important for us as clinicians and professionals to support social affirmation of clients is to check our own biases. we all have biases towards different things, and that's not inherently bad. It just is. This is how we're socialized, but we need to check that for ourselves and make sure that we're not putting our values on the people that we're working with. Um, Refer to an experienced specialist with expertise if available. And I think, this is supported in the documentation. And, Miss Sarah, I really appreciated that you shared with the participants that you don't work with adolescents and children just because that you don't have experience there yet, and that you want to be trained. And that's the ethical thing for us to do, is work within our scope of practice, work within our expertise, work within what we are able to do. And we need to follow our separate codes of ethics regarding how we do that. Again, support regarding social gender affirmation, providing an affirming place that this person's going to be called what they want to be called, addressed by the appropriate pronoun, even when other people aren't doing that. And that goes back to that question about how do we support children and adolescents that are expressing, hey, that's not my name, or I'm really a boy, even when the parents are against it. We can meet both the families and the person and the client, in a respectful way, and still provide affirming care. And I think I typed something in the chat about that, about kind of what that looks like in my own practice. But learning things, learning how to talk about and educate about things like gas, which is a wardrobe piece that sort of helps transgender women, with bottom dysphoria. Talk about binders and prosthetics, and using their names and pronouns, supporting their coming out process, not pressuring them to come out, honoring if they've disclosed to you their identity but they've not disclosed to someone else, honoring that and respecting those limits of confidentiality. Finding social support groups for our clients. Social support becomes very important, not only for just filling the gaps, because so many trans people lose that social support, and they find it again within their communities, and like Facebook is an example of one, and finding like these community centers and things like that. I wanted to include a section about safety concerns as far as social coming out, because I think that this plays into these last two playing together. There are serious and significant safety concerns. I frequently hear from parents, this is a barrier for them to full acceptance of their trans child, is that they're worried about their safety, that this person is going to be beaten and harassed, or potentially killed, or heckled or catcalled or made fun of or ostracized in some way. And that brings me to this last part about what does it mean to live full time as a whatever, right? Because this is a criteria that's in the WPATH that is recommended for more extensive genital affirming surgeries, is that somebody needs to live 12 months, continuous 12 months in a role that's congruent with their gender identity. I'm going to assert that sometimes that is just not safe, and we cannot all do that all the time. And that sometimes it's, we can't present as how our gender identity is for a safety concern, whether or not that's physical safety or psychological safety. I'm very lucky in that, I'm privileged. I'm perceived, I'm very privileged. I'm steeped in privilege. I'm white. I'm perceived as male. I'm perceived as heterosexual. Although none of those things, I am white, but all the rest of it is just, and I am male, but people give me that privilege. They don't recognize that I'm part of a marginalized population. But some of my other transgender, community, like transgender women, and especially a person of color that's trans, that it is scary to be trans. So we need to educate regarding safety, help them enhance their safety, and support them if it's not a safe thing for them to do, to run about and and express their gender openly, when it's not safe to do so. And that becomes more pertinent later when we're having to do documentation about what it really means to live full time as a woman or as a man or something else. And we'll talk more about that later on. Considerations working with children and adolescents through social gender affirmation is that family support is a buffer against these negative mental health outcomes. We talked about the risk of suicide And the number one identified support and mitigating factor for suicide among children, adolescents, and young adults is family support. Having a supportive caregiver that is going to say, "I love you no matter what," is the one piece that really, really makes a difference. Second only to like community and peer support. And so engaging our families, and yes, we know that you don't understand what it means to be trans, and it's important that we meet your kid where they are right now, recognizing that it may or may not be the same later. But offering that acceptance to these kids and adolescents is super important as a protective factor. Research indicates that waiting to initiate medical treatment for gender dysphoria in adolescents that meet criteria actually can cause harm. And so if somebody really is very, very dysphoric, are we going to withhold treatment just because that they're not 18? Or are we going to try to advocate for them to get on a blocker or to get, gender affirming hormone therapy, so that, at an age appropriate level, so that they can begin to experience relief from gender dysphoria, which frequently exacerbates comorbid mental health symptoms of depression and anxiety, or even trauma-related symptoms from being, part of a marginalized population. Additionally, adolescents and teens may need support with tolerating uncertainty and ambiguity as they explore their gender. And their family may also need support in this. So one day my kid wants to be called he, him. The next day they want to be he, they. And so sometimes the parents get very confused. The kids get really, they're like, oh, am I not trans, or am I trans? And we can just meet them where they are and just be a support person and a reflecting person back to them as they're doing that gender exploration in a safe environment. Another thing that I have found working with adolescents, that they might need support tolerating uncertainty as they wait for their parents to get on board, since the parents are the ones that are providing informed consent for these medical interventions like hormone blockers or hormone replacement therapy. So these are ways that we can support children and adolescents through gender affirmation. There is different ideas in the literature about interventions with prepubertal children. The widely accepted method is sort of like the Dutch method. Is what they do in Amsterdam, and it works really well. It's watchful waiting, right? We're going to affirm them, we're going to support them, and wait and just see what happens. Not every child that expresses gender dysphoria or gender nonconformance is going to grow up to be a transgender person. And there is no recommended medical interventions for someone who has not yet reached puberty, which is particularly important in Tennessee, since now that's against the law anyway, even though we weren't doing that before. No one is recommending a medical intervention for a pre-pubertal person. And as Ms. Sarah was talking about, WPATH guidelines recommend that attempts to alter and express gender aren't ethical. Conversion or reparative therapy is unethical. It does more harm than good. And so that is something really important to consider when we're working with children and adolescents. How do we support our clients through legal gender affirmation? And ways that we're going to do this are, we're going to provide documentation when needed for name changes or gender marker changes. We're going to find and refer our clients to affirming legal professionals if that's needed. It's typically not, but sometimes it is. We're going to provide support for mental health as needed throughout the process. Again, this is, the number of folk, including myself, that were terrified to go to court to get their name changed. Oh, what if they tell me no? Or what's going to happen when I go to the Social Security office? What's going to happen when I go to the DMV? And we need to provide the support for them as they're navigating these really difficult obstacles to becoming, their more authentic self. And also doing advocacy work to make these documents easier, to make these changes easier, advocating at the legislative level, for these laws, especially here where we're living in Tennessee, where, the anti-trans rhetoric is high right now. This is a sample letter taken from transcendlegal.org that just talks about the the federal government requirements. So like if you're changing something on Social Security card, this is something they're going to want. Um, you know, it's going to state the physician's full name, identify the name of the patient, by both their chosen name and also their current legal name, provide their date of birth, describe the kind of relationship that you have with them as a doctor and a patient, or a therapist and a patient, that you've treated, and that you have evaluated that they have had appropriate clinical treatment for gender transition to whatever new gender it is, either male, female, something else, non-binary. I think it's important to point out that this appropriate clinical treatment for gender transition, what does that actually mean? It actually means nothing, because when the person tells you they are male or female or something else, and that they feel affirmed in their gender, they've completed it. It's not about what surgery have they had. It's not about how long have they been on hormones or how long they wear skirts, right? It's about that person has talked to a therapist. They have started hormones. They have decided that they don't need any of those things, that the person is telling you, this is what I am. We believe them. I declare under penalty of perjury that this is true and correct. Obviously, I want to say, the word on this letter is it's physician, physician, physician. Of course, if you're a social worker, don't identify yourself as a physician, because that would be unethical. I've written these letters. I identify myself as a licensed clinical social worker. These letters work. And if the client asks me for that documentation, and here where I live, it's not been a problem to write these letters. Make sure that they're printed on letterhead, and then signed. So how do we support medical gender affirmation? First of all, again, this accurate gender dysphoria diagnosis to make sure that the person receiving the medical intervention for gender dysphoria actually has gender dysphoria. And this also eliminates an obstacle or a barrier to using health insurance or getting a medical professional to treat them. So they're going to require that diagnosis of gender dysphoria. Utilizing a collaborative, integrative approach with other professionals. The number of times where I've communicated with a prescriber or communicated with a surgeon, it's important so that these clients are getting the care that they need, even when they have comorbid issues. That somebody might be trepidatious about, doing something like hormone replacement therapy or some sort of surgical intervention if the person is depressed. We need to be talking to and with other professionals to get all the comprehensive treatment, that's also not an obstacle to them getting gender affirming care. Again, providing that supportive documentation and referrals to gender affirming professionals. For hormone therapy and blockers, the recommended thing is this informed consent model. They don't need a gatekeeper. For children, or not children, but adolescents and teenagers, the parents are frequently the gatekeepers. And so working with them to understand what's needed and why, and what the risks are, what the benefits are, what parts of hormones, hormone treatment, either via a blocker or, estradiol or testosterone, what's considered reversible, what's partially reversible, what's irreversible, making sure they understand all the risks, the benefits, again, discussing fertility in a really frank way so that people can make the best decision for them, is very important. And then, utilizing these WPATH standards of care for gender affirming surgeries. That's the requirement. It's either 1 or 2 letters required, depending on, what sort of surgery is coming up. And I would encourage everyone working with a transgender person to be aware of like some red flags. Like if a person's going to pursue gender affirming hormone therapy, and the person that they're going to see is requiring something that's outside of the recommended guidelines, like, well, before I'll do HRT, you have to have a letter. Well, we want to make you, or you have to be in therapy. We want to be on the lookout for those red flags, because that means that provider isn't culturally competent. That means they haven't had the required education to be able to make, to treatment decisions that are more ethical, unless there's some outlying reason. And again, we can collaborate, educate, and do this integrative approach with other professionals to help our clients get access to treatments. Considerations working with children and adolescents through medical gender affirmation. Again, no medical intervention for prepubertal children is actually recommended. We can do therapy. My anecdotal evidence is that when a kid is brought to me for gender therapy, and they identify as a gender that's not aligned with their bodies, many times if the parents are supportive, the kid's actually really happy and well adjusted, and so they might not even need any kind of therapeutic support. Puberty blocking medications, if it can begin at 10 or stage 2 and beyond, and will need documentation of diagnosis. This is where that accurate diagnosis of gender dysphoria and then collaborating with medical professionals becomes important. And then again, for adolescents that meet criteria, waiting to initiate treatment can cause harm. This is a study that came out of the Netherlands at the gender clinic there, and it's pretty cool to see what happens, because you've got the gray line, which is just general functioning, the orange line, which is emotional and behavior problems, and the blue line, which is measures of gender dysphoria. And you can see that already when people begin somewhere between, before they start any sort of puberty suppression, after puberty, to starting cross gender hormones or affirming hormone therapy, you can already see that their levels of general functioning is starting to improve, and that their emotional and behavioral problems like depression, anxiety, suicidality, self-harm are starting to go down. And then when these individuals are able to start gender affirming hormone therapies, taking testosterone or estradiol and a blocker, they really start to feel better. I mean, these people start to experience much less gender dysphoria and continue making strides towards, better overall mental health, with continued reduced levels of emotional problems, continued reduction in gender dysphoria, and continued improvement in overall functioning. This is another graph here just to talk about the importance of medical gender affirmation and why it's so important to support transgender people accessing this care. This is a study that talks about the number of folk that were satisfied or felt neutral or felt dissatisfied after receiving medical gender affirming care. Overall transition rate, 96% satisfied. They've got separate ones for hormone therapy, top surgeries, bottom surgeries, hysterectomy, electrolysis, which is hair removal, facial feminization surgery, and tracheal shaving for that Adam's apple for transgender females. So, overall, most of us are satisfied with our care. Another part that's really important to acknowledge looking at this this information is that dissatisfaction doesn't equate regret. It doesn't equate, oh, wait, I'm not really trans. It just means that they were dissatisfied with some aspect of that, the results or some aspect of that procedure.
Hey, Samuel, if
yeah.
I could interrupt,
Yeah.
I'm so sorry, but we have about 15 minutes left in this presentation, and I know some people have questions.
Yeah.
Would this be an okay point to pause and take some questions?
Can I have like 2 more minutes?
Of course.
Okay,
Yeah.
thanks.
Yeah.
All right. Yeah, I didn't know this was going to take me so long. I was worried I wouldn't have enough to say. So
a lot of good information in here.
So what about these people, concerns about detransitioners? That's what, I've got it in quotes. This survey about people who have reported detransitioning. This was a great piece of stuff to read. The reference is in my presentation, which they'll share with you. But the people who have detransitioned were actually less likely to have accessed medical gender affirming care like hormones or surgeries. And detransition means different things to different people. Specifically, most of these people were reporting not that there was regret or that I'm not actually this gender. It was that it was so hard to be trans that rather than do all this hard stuff, it was just easier to give up. It means that I'm going to, dress as the gender that I was assigned at birth so that I don't have to confront my family or that I can get a job. And then there's external factors were reported in this study as being the biggest part of a reason for making the decision for whatever detransition meant to that person, like negative family pressure, societal stigma, difficulty finding employment. And I believe the statistic was over 83, I think it was like 83% of people that had reported detransitioning cited an external factor. And like I said earlier, detransition and regret are not the same thing. If we look at this graph here, regrets are not about receiving gender affirming care. It's very, very rare for someone to experience regret. Guidelines for gender affirming surgeries. This is in WPATH. The one that I wanted to talk a little bit about is this 12 months living in a gender role congruent with gender identity. And with this right here, again, I'm going to talk about safety, that if somebody is living and they're telling you they're a woman, they are a woman and they are living as a woman. And I would say the same thing for men. I would say the same thing for a non-binary identity, is that they're already living that because that's who they are, but they're living it in the safest way that they can. When we're creating that documentation for, to support gender affirmation, we want to make sure that we're including things like identifying information of the client, including their chosen name, legal name if applicable, their date of birth. I include their pronouns if that's not already been changed on their documentation. Results of assessment, including documenting that gender dysphoria diagnosis, describing the assessment and or duration of therapy, and that a short sentence about that therapeutic relationship that you have with the person, a statement saying this person meets criteria and that this is a medically necessary and recommended intervention based on WPATH guidelines, a statement saying this person is able to provide informed consent and has provided informed consent, and then indicate that you're willing to be part of this team to give the person what they need. There's a sample letter in there. Feel free to lift what you want. And thank you. I'm sorry about taking so long, but thank you for
that. That is fantastic. Thank you so much. And I know that a couple of people have asked about getting that template. Would you be willing to share your slides after the presentation?
Take what you will. Absolutely.
Fantastic. So we'll be in touch about that. Great. So yeah, several people have asked some questions. One person asked about if you could explain a little bit more about how someone could identify as transgender without having dysphoria. That is the dysphoria primarily indicating the emotional impact? And how would that dysphoria not be a byproduct of being in a social environment that doesn't accept them and applies additional pressure? Also, before I forget, before you answer that question, please, if you're looking for CEs, please do check in with the Q&A again at this time. Thanks.
So if I want to make sure that I understood the question, because I think this comes up a lot, is how can you be trans and not have gender dysphoria?
Mm-hmm. Yeah, that is essentially the question.
Yeah, and so, not everyone that identifies as something different in their brain is going to experience the distress. Gender dysphoria talks about, I am experiencing distress from society or from even internally, right? Like that there's something that's causing me some sort of discomfort or distress because that my brain and my body are not congruent. I have met many folk that identify as trans that are fine however they're presenting. Maybe, I'm gonna use breasts for an example for someone that was assigned female at birth that identifies as male or non-binary, right? Maybe they have small chest, maybe they're comfortable wearing a binder and they don't have dysphoria, right? Maybe their size of their chest never even mattered, right? If we talk about, I'm trying to think about other things. There's just a lot of transgender people that don't feel the need to conform to societal pressures. And that right there is enough to prevent them from getting gender dysphoria, right? You might meet somebody, and I'm gonna pick some gender things that may come out, right? Somebody that has hairy legs and hair on their lip and also has breasts and wears construction clothes and paints their nails with a shaved head. And they might be fine. and whatever they tell me their gender is what they are, right? But I think, does that answer the question, you think, Rachel?
I think that's a fantastic answer. Yeah. Um, someone asked for a point of clarification. Electrolysis, is that the removal of hair?
Yes. So there's two different ways that, well, and then there's lots of ways we can get rid of hair, right? But like electrolysis is actually a procedure that is performed by someone trained in electrolysis using a little thing that looks like a needle, and it actually burns the hair follicle right out of their little face. And it is a more permanent hair removal thing, other than like laser, which is using a laser to do the same thing. But electrolysis, I think, is thought to be more effective. It's more costly, um, but overall more effective. But I'm not an electrolysis expert. Caveat.
Thanks, Samuel. Um, Somebody asked if anybody has resources for physical modifications like prosthetics and binders. Dr. Ross did a fantastic job of providing several resources for people of all genders. I don't know if you can see what Dr. Ross has shared, Samuel, but is there anything that you would add um, to those resources?
Ooh, gosh, that's a really hard one. So, I think doing some research for yourself, and learning where they are. And, I happen to be transgender. And so I research prosthetics, for my own self. And so learn, talking to people, find out what works, what doesn't work, what's a good idea, what's not. And then also recognizing that everybody's body shape and things like that also kind of are particularly different. And so a lot of it's going to be trial and error, unfortunately. But maybe that's something that I can work to compile as a list of different, at least, websites where people can go and investigate, um, different options.
Yeah, and maybe this is something that we can also crowdsource if we can come up with some collaborative way to get resources from all different attendees, because I think a lot of people here might have good resources for that. Great. Somebody asked a question that I'm not entirely sure I understand, but they said, seems like there's an overlap in criteria for diagnosing gender dysphoria in children and homosexual leanings. I think that this person is pointing toward a correlation between gender dysphoria and sexual orientation, or like some kind of queer identity in childhood. Any thoughts on that?
Yeah. So without having the DSM right in front of me, and looking at it, so people that experience gender dysphoria in childhood don't all grow up to be transgender people. Okay. So what is the research does say is that it is very likely that if you are demonstrating criteria that meets gender dysphoria in childhood, that there is an increased likelihood of you growing up to express your sexual orientation, or to be sexually oriented in a homosexual way, right? To be gay. They grow up to be gay. If gender dysphoria persists into adolescence, it increases the likelihood that that person is going to continue to be transgender in adulthood. And if I've messed that up because I don't have the DSM right in front of me, feel free to correct me. But I think that might be what that person's confused about.
Yeah, that's a really great answer. I think that that's most of the questions. A couple people have noted throughout, I think maybe related to your presentation and just in general, that they'd be interested in peer support work or the buddy system that someone mentioned earlier. So several people seem to be interested in that, and I'm hoping that attendees are able to get together to talk more about that. Do you want to respond to that piece at all?
Yeah, absolutely. And that is something that, that I have utilized is it's finding resources. And I've reached out to different places like Appalachian Outreach with consent from my client to ask for that assistance. And, we have provided, the Appalachian Outreach has been able to provide a person to go with someone to court or go with someone to the doctor. And it is very, very helpful. And so that's one existing resource I know about. And I don't know if they can always do that, but that has been successful before. And I definitely think we should collaborate as a group of clinicians to make that happen, and just as a community.
I have a question, because I haven't seen any others that have popped up, but I've been struck by how many resources exist in Maryville, which is a much smaller population than Knoxville. And I was just wondering if you had any thoughts about that.
Well, you know what? I have a thought, and it's that I think that the community here is well integrated, and I actually reside in Knoxville and I commute to work in Maryville where there is this resource. And I just think that the community is pretty cohesive here. And it's maybe that's because it is smaller that they're able to kind of get together and really put their heads together and do stuff. So I'm wondering if that's not it. And then Appalachian Outreach is one that I've mentioned a couple of times, and I happen to know the person really well that started that, and then that person's also a social worker, and so it's they're sort of kind of connected. There's like this web of support that's weaved through that kind of smaller social circle. I think that makes sense.
And we have just a few more minutes, but someone has asked, how do we help adolescents who identify as trans and then express confusion about how to identify their sexual orientation? For example, they might ask, does this mean I'm gay?
Yeah.
How do you think about that?
Great question. Yeah. So I'm going to share a small little story about that. When I came out as trans, I had been out before and identified previously as a lesbian, married a woman. And so that challenged not only my sexual orientation and my sexual identity, but my partner's as well. And I sort of had to be thoughtful and mindful about how I felt. And so that, what I would express to an adolescent that was coming to me with that is, think about how they feel and what word resonates with them. And they can choose a label or they cannot choose a label. I've used the word queer to describe myself before, and I know that that's a hard word for a lot of people to hear. But I think that people have the option to sort of identify in what way feels the most comfortable for them, and that they don't have to pigeonhole. But I was accused of now being straight, that I wasn't allowed to wear a rainbow tie no more because I was straight now. But this is part of my identity too. Is even though I'm married to a female person, that they get to decide what their identity is, and that just because that they transition doesn't mean that they are not part of this broader LGBT community. And maybe it is. Maybe if that's how they want to be identified is as a straight person, they can claim that identity too. And that it's not prescribed.
And I think that might actually partially answer the elaboration that Charles gave. Like after they've accepted the gender identity, but then they're attracted to the sex that would be heterosexual. And so I think it's just a matter of exploration of all of this and learning to understand themselves and then helping them settle on the terms and identities that they feel best match them.
Yeah, and what I would add to that too is if we recognize that everything exists on a spectrum and that it's dynamic, that whatever we are today doesn't dictate what we have to say about ourselves tomorrow either. Mm-hmm. That it is a dynamic process. I think gender is dynamic. I think sexual orientation can be dynamic for some people, and that it can change over a lifetime. There's actually a good body of research that talk about, after you transition, your sexual orientation really does change for some people, not for everyone,